techniques of the week. This week's been interesting. We're going to focus on something that has popped up several times, and I think it's done with a lot of variability, but it needs to look good because it's used in trauma, it's used in elective surgery, and it's probably the one suture technique that patients unanimously love and surgeons love, and people in training for surgery like to do to show off their skills, but it's not often done particularly well. The subcuticular, or better known as the intradermal suture. Its benefits are it doesn't give you stitch marks on the top of the skin because it's all in the dermal layer of the skin. It's one continuous suture. It's really useful for long continuous wounds, and in terms of surgical benefits, it's fast because you're not cutting knots continuously. The first important part in your subcuticular is suture selection. You have three options really. You have non-dissolvable and dissolvable. Typically, it's going to be a non-dissolvable suture because it's buried and you're tying your knots at the beginning and at the end. However, you can do it as a non-dissolvable suture and pull it out in a week. This is really useful, for example, with eyelid surgery, in pediatric surgery, because in children you don't want to cut sutures out because they often don't like it, they get very upset. So you can just unzip, you can just pull out the suture in a week's time, 2 weeks' time, when the wound is healed. Similarly, in eyelid surgery, to avoid suture marks on the skin edges, to avoid inflammatory responses from the knots, you can just pull out the suture in 5 to 7 days. But we're going to focus on the buried subcuticular or intradermal suture. If this is something which you're interested in, like it, subscribe to it. We do this every week. Techniques from surgery, my top tips based on things that I've seen people struggle with. So suture selection for the subcuticular or intradermal suture. Monofilament or braided. Examples being PDS or Vicryl. Another example of an intradermal suture that I would use to keep it buried and hidden would be monocryl. Why would I pick a braided over a monofilament or a monofilament over a braided? Typically, I will use a monofilament suture, so PDS, or actually more realistically, I'd use monocryl. Because it glides nicely, the suture will glide through the wound, and it's not going to cause much in the way of additional reaction when it's dissolving. Where I would use a braided suture such as Vicryl is when I think the dermis is a bit thin and the suture, a monofilament suture, will just cheese wire and rip out. So when I want to get a bit more purchase, I would use a braided suture. Many may also prefer the braided suture because the suture material itself is softer, whereas the monofilament, some describe it as being a bit pokey. Alas. Let's get into this. So we're going to do this twice, once with the monofilament, once with the braided. In both cases, you should use a non-dissolvable, you should use a dissolvable suture which is undyed. I am going to use a dyed suture so you can see what I'm doing, but you would typically use a dissolvable, undyed suture. The first important tip is you need to be flexible with how you hold your needle holder. So you have the mounted grip and you have the palm grip. If you need to revise this, check out some of the latest MedSync videos and shorts. We talk about these tips. You need to alternate between the two when you're doing this technique. So to start with, you need to anchor your suture. There are several ways of doing this. I'm going to show you both ways with both techniques, with both suture materials. So the way I tend to do it is I will take a bite from deep to superficial, push it through, these maneuvers that I'm doing here that make me slightly faster than many, you can learn in our other videos. I'm not going to go over those here today because that is not the purpose of this particular tutorial, but it is in other previous sessions that we've covered. So now I've buried my knot. I just tying it on one side and cutting the short suture flush with the skin but above the knot. Let me zoom in on that for you. Look at that. So you can see the knot, you can see me cutting above it. So you go on, you slide down, you angle it, and you cut. And that stays anchored inside. And then we need to start running this subcuticular. So the first thing I do is I go back on myself a little bit. Why do I do that? Because otherwise there's a gap at the front. So I go back on myself just to capture the apex. You're going intradermally. You need to get enough bite so that the suture doesn't rip out as you pull the suture. As you pull the suture, notice that I'm pulling it in line with the wound. I'm not pulling it this way or up in the air. I'm pulling it in line with the wound. You see how it closes that bit nicely? Great. And then I do the other side above my previous suture that's got the knot on it, otherwise it will cut it out. Go through. That's a bit too superficial there. Mount it straight away. Mount it now and pull. Again, in line with the wound. And look how that closes really nicely. Let's zoom in on that. So I've got my apex nicely closed. And now you go in opposite where you came out. So if I zoom out, you'll see how my hand position changes between two grips. So I'm currently palmed. You need to have excursion. This is where I saw flaws this week in people suturing, and I had to redo what they did. People that I was training in theatre. You need to go in at 90 degrees and curve it all the way around. And you just need to feel the needle pass. Don't force it, just feel it glide through. You shouldn't be forcing your needle through, otherwise you bend the needle, you rip the tissues, and are forging a path that it wasn't going to take anyway. Pull it through, mount it straight away, exactly where you want it so that you don't have to reposition it again. And then look how that closes. Let's do the opposite side and then I'll zoom in a bit more. You go in just beneath the epidermis, in the dermis, superficial dermis, deep enough that you've got purchase, superficial enough in terms of depth so that you do not see it through the skin. You don't want the needle to pop out, but you do want it in the top layer of the dermis. Again, I'm pulling my suture in line with the wound. Now let's zoom in. Here we are. Notice I'm in the palm grip again, so I'm alternating between the two grips. It's fine if you don't need to, if you've got a flexible wrist like that, but I find to get this excursion, what I don't want to do is go in at this angle, because then I only get the edge. I want to go in, go that way, and then curve it down. Your forceps is ahead, giving you counter traction, and then I divert my hand. So I've swung it from here, and then suddenly I'm up here. And then you push through, pull through, grab it with the forceps along the body, not the very, very tip, between the teeth of the forceps. If I go under this loop, I'll get caught in a knot. So anticipating that, I'm going to push the loop down, this loop of suture here, and grab the needle on top so that I don't have to untangle myself. And you pull through. And then you go in opposite where you came out. I'll keep this one zoomed in. then mount it straight away and pull. And then let's look a bit more broadly. Again, it's about the alternating hand positions. You want to try and be at the same depth on both sides, otherwise your wound edges, your closure will not be equal. If you don't bring dermis to dermis and epidermis to epidermis, the wound will not heal. If you bring epidermis into the wound, you will get a cyst. Here we are. So I'm going to do one more on this side, a reasonably long bite to get to the apex. Again, I'm pulling it in line with the wound. And then on the other side, I need to anchor my suture. And to do that, you're going to have to do a bite that has good purchase. Otherwise it will rip out when you come to do your Aberdeen knot. My needle's here. And you leave a loop. And then we have our Aberdeen knot. So you make a loop. Your index finger pulls the suture through. You don't let the needle end come through on this side. You just slide the inferior loop, the lower loop of suture is what you pull, and it makes the knot slide down. I'll show you again on a wider view and then I'll zoom it in. I pull, that didn't work very well. I pull the suture through the loop, and then it's the lower thread that I'm gliding the knot down with. And then let's zoom in. So we do that again. And then it's the lower loop that I pull. For a monofilament, you do 4 to 6 knots. For a braided, you can do 3 or 4. This is a monofilament, so I'm doing 4 to 6. And if you drop the loop, it's fine, just start again. And then you can see all my knots are here, like so. Nice. Ooh. As expected. And then when you're finished, you bring the needle through the loop and slide the knot fully down. Now you need to anchor the knot inside and bury it, because you don't need it popping out on top. So you go in at the apex and come out somewhere on the side that's anaesthetized if the patient's awake under local, and pull. And then cut both the skin. I pulled it a bit too hard so it's popped out. That doesn't happen in Vivo. So that's the buried subcuticular. The key summary points are: anchor your knot at the start. I prefer just to go deep superficial, tie a knot. I go back on myself at the start, continue on the side, and then once I've done the back bite and the first forward bite in the very apices, every time I take a bite, number 1, it's opposite where I just came out. So if I've come out here, I go in opposite here. You can kind of see the suture if I zoom in a little bit. You can see that I'm going in opposite where I came out. I'm going in opposite where I came out. And you can see that the number 2 is that the excursion in the skin is a decent bite at a decent distance from the wound edge. Otherwise it just cheese-wise out. And then at the very end, you want to do an Aberdeen knot. So that's the technique which is most commonly used. The next technique which we sometimes use is the pull-out subcuticular. For that, you use a non-dissolvable suture. You go in at the apex and come out inside. And then you just do the same thing that we did before. So you go in the apex. I think this is a really good way to practice your subcuticular and really perfect it if you do both techniques. So it's a bit difficult to purchase on that. It can often be good to use a slightly larger needle than the one I'm using, because then you don't have to struggle too much to grab it. Again, I go back on myself a little bit because otherwise there's a big gap at the beginning, but I will show you what to do if you have gaps in your sutures after this one. It's a nice way of avoiding redoing all of the suture just because you've got a gap. So you see how going back on yourself closes that first bit. Really, really important. But only for the first one. I don't tend to go back on myself each time, otherwise you don't make progress. And then I just go in opposite where I came out. I mount it straight away. Pull in parallel to the wound itself. Leave a short end on the other side, because this is a pull-out intracuticular. If you're fearful that you might lose your suture, you can put a clip on this. And again, you just go in opposite where you came out. The angle starts like this, and I rotate my wrist, or flex it rather, so I follow the curvature of the needle. I'm not forcing it, it's following its natural planes. Mount it straight away, pull. And then, so this is a really useful suture for children, for eyelid surgery, and then you can just pull it up. Or patients that have darker skin types, more prone to darker scarring. You don't want to do lots of sutures that come through the epidermis. You can do a pull-out subcuticular to reduce the risk of hyperpigmentation at the suture marks. And then, so you need to curve this round and come out in the apex of the wound. So rather than take out the whole thing, it's just the end point that I need to redirect. So there we are. And I keep the tension pushing it forward. I grab it with the forceps and then I pull it through. And then all I need to do is capture this apex and come out. And then when you've done this, just make sure that your suture moves, so that when you come to pull out in a week, it moves. So this is the pull-out subcuticular. What you do now is you cut a suture length there, you cut a suture length there, you get some butterfly strips or steri strips and anchor them here, put them across, and then a week's time you pull it out. So this one over here was the buried subcuticular, this was the pull-out subcuticular, and the last one I'm going to do is the subcuticular with the braided suture rather than the monofilament suture. For the buried suture, it was dissolvable monofilament. For the pull-out suture, you use a non-dissolvable suture and leave the ends and pull them out in a week or so. This suture, the coated Vicryl, I would use it in the same way I use the monocrylor PDS. I'd anchor the suture. I'm going to show you a different way to anchor it at the start, and that's going to be a traditional knot on both sides. If I've got a bit of a gap for wound under tension to start with, I might do a bite here on this side, similar to a deep dermal, Always pull your suture in line with the wound. Leave a suture end. Rotate your needle holder. Get good purchase. This is a longer needle than when I had the PDS, so I have to curve it quite quickly, otherwise I'll be too deep. And come out on top, disengage the needle, push it through some more, and tie it off. So this is the other way to anchor your suture at the start. Compared to the other side, when I did with the monofilament, I only put a knot on one side, I didn't go across the other side. Cut it flush, scissors go in the palm, and then you proceed as normal. But because I'm already in the very apex, I'm just going to take a small bite in the corner, go above my knot of the deep dermal. Long needle so it's easier to grab. And I'm just going to go in opposite. Mount it straight away. We're going to finish with the Aberdeen knot. And you just feel that it's got a lot of grip compared to the PDS or the monoculture monofilament because it's braided. But a word of advice is that if it's in trauma, you may have done a really good tidying up of the wound edges, but anecdotally, there's a higher risk of infection. So with a braided suture, it can also complement that risk of infection that comes with traumatic wounds, because the braids can harbor bacteria in them, whereas monofilament sutures in theory do not. So maybe in the case of elective surgery, I would do the braided suture, dissolvable in patients with thinner dermis, so the really elderly or really small children. I'd use monofilament for everybody else. Okay, so now we're coming up to our Aberdeen knot. So that's closed really well. I said I would show you what to do to correct a step or if there's a gap. So I will show you that. So the Aberdeen, I need to make a small gap so I can do the anchoring on the opposite side. And then, so you pull the suture with the needle. This is the needle end, this is the loop. Pull the suture through. Don't let the needle come through, keep it on the outside. And then you pull the lower suture and watch your knot glide down into the wound. This is a braided suture, so I only need 3 to 4. I'll zoom in so you can see a bit more detail. Here we are. Let's have a look at those knots. Here we are. Okay, and then you come through. And then once you're happy with your knots, you put the needle through the loop, pull the suture, and then you take a bite in the apex and come out. You cut flush with the skin. Now I'm going to show you what to do if you have, maybe like on this one, an overstep. You get really small suture, like a 5/0, really fast dissolving suture, and you correct that step. So I need to lift this side up and that side needs to go down. So take a thin bite on this side and a deeper bite on the opposite side to lift it up, like so. That's how you correct your steps or gaps. Rather than redoing the whole thing. If you got value out of this, like it, share it, subscribe. We also have our monthly members only live, so we've got one at 5:30 in an hour's time here live on YouTube, and then we have our interactive off platform via the MedSync website. The next sessions will be on tendon repairs. It's a 3-part series on the modified Kessler, the Adelaide, and the cruciate repairs, and the epitendinous continuous, and the silver scold will also cover how to design your skin incisions, Brunner, mid-axials, and how to retrieve a tendon. You can go to medsyncltd.com/event if you need to get yourself some simulated kit. Check the link in the description below. I hope you got value out of this. This was a tutorial on the intradermal suture, which is a really popular suture. You have to be able to do this well, and it's worth practicing before you go to the operating theatre. Until the next time.